Hi, my name is Steve Nelson. I'm the Director of Value-Based Payment and Performance for Millennium Collaborative Care. I'm here today with Sheila Kee, Chief Operations Officer and Executive Vice President of Niagara Falls Memorial Medical Center, to talk a bit about the Innovation Fund program and the efforts underway at Niagara Falls Memorial. Sheila, thank you so much for sitting down with us today to talk about it. Now, your organization was really quick to apply for funding for the Innovation Program because you knew there was a really big need in Niagara Falls, and so you jumped right in. Can you tell us a little bit about what the need is and what programs you're currently undertaking today for innovation funding?
Well, the need in Niagara Falls is huge. There's a couple of things that make it very different than many other communities that I've served. One is, quite unfortunately, there's a lack of family support. We find on numerous occasions how people are dropped off at the ED and that's it, and family just keeps going. Why that is probably very low economic status for the community. We also find, and I don't have empirical data, and I've been trying to get this, is I think there's a larger than usual share of people with mental health issues in Niagara Falls. I think that's from, again, a very poor economy. Back in the 60s, 70s, Niagara Falls was a booming metropolis. Today, it keeps losing its status. So the poor economy is driving a lot of health issues, behavioral health issues.
So behavioral health was a big focus when it comes to these innovation programs. Can you tell us a little bit about the four programs that the hospital's taking?
We have one program where we go out and screen folks for cardiovascular and diabetes. These diseases are very pronounced among seriously mentally ill people, for example, folks with schizophrenia. We are also trying to make sure that people who are hospitalized are re-engaged with outpatient mental health care. We do that through a 7-day, get them to an outpatient mental health appointment in 7 days. And we're doing that through home visits, which is really cool. I mean, we're learning a lot from that. Things that can reshape how we deliver behavioral health care for a long time. We also have an ED hotspotters program for the most, how do I say it, the top ED hotspotters. There's 26 of them now, and these are people with like 30, 40 visits. They have very drastic needs. Now that we've eliminated all of their visits, although 16 people have graduated from our program so far, meaning that they stopped coming to the ED, which I think is great news for them and for the community. But it takes a tremendous amount of effort with just one client to change their life and how they utilize the ED and the hospital. We also have a medication adherence program, which is probably our biggest challenge, is to try to get people to understand that with serious mental illness, if they're on antipsychotics, it's a good thing. If they can follow doctor's orders, they can at least stabilize their condition. Some can recover. So the medication adherence piece also involves dealing with clients who are on a state list who are not compliant with their meds. We speak to them in the ED. We have drugs delivered to them at the time that they're discharged from the hospital, and we go out to their homes to deal with their medication non-compliance. So all those wrapped around together really talk about multi-strategies for dealing with folks with serious mental illness.
And it sounds, I mean, the community piece sounds like it's huge, and normally if you're a hospital, you can't help but take a hospital approach, right? We're going to get people in and see them, whereas you're taking the approach of getting out into the community. Why was that important in particular, do you think?
Well, first of all, I'm a hospital administrator, but kind of an unorthodox one, because I believe that health starts in the community, not in the four walls of the hospital. And that we can really benefit hospital operations through our community work. I was head of the Community Healthcare Association of New York State, very involved in federally qualified health centers and other efforts. It's just in my DNA to take a community approach.
Sure. Now, you've seen some great results so far. You mentioned the Hotspot Program and those
Right.
who've been able to graduate from that
Right.
program. Can you tell us a little bit more about sort of what you've learned so far and some of the success that you've seen?
Right. So with the home visits after someone has been hospitalized, prior to starting that, we only were able to get maybe 50% of these folks to go to an outpatient mental health appointment within 7 days. That's really poor, you know? Now we're at 90% compliance when we go to their homes. Very interesting. They think, "You're coming to my house?" Yeah. We bring a little, snack with them so they know when you break bread, sometimes it opens up the conversation. And then as we talk to them, we find that we see their surroundings. Once in a while, they'll have a family member there. We get to know the client much better, and they get to know us. And I think what happens is they see that we really care about them. We're coming to their home. We've had visits where the client had a dirt floor, but was so proud that people would come to her home. She lit little candles and things like that. So it just has so much more meaning. And then after that home visit, we try to tell them, come back to the clinic and get your care. We are seeing, I don't have really good empirical data, but we're going to be analyzing how those home visits reduce readmissions to the hospital and reduce subsequent ED visits. So we'll have that data for you soon.
Yeah, that's
And
great.
I think that it will be very good results.
I think so too. Well, Sheila, we appreciate your time so much today.
Oh,
Thank you.
yes,
I
okay.
Look forward to continued success.
All right, great.
Thank you.
Thank you.